Hello, I'm Sven Gudmund Hinderaker, Professor at Center for International Health, University of Bergen. In this presentation, I will tell you about how to control the tuberculosis epidemic. There are basically two potential principles: either making the population immune to tuberculosis or removing the source of infection so that susceptible are not infected. As you have seen, the source of infection is a sick patient transmitting the bacteria by coughing in the air. This infectious air is inhaled by persons sharing the same space. Removing the source implies to treat and cure them. There are various conceivable approaches to this. Finding the sources means either examining the whole population regularly or examining high-risk groups. Just symptomatics would be such risk population and are the main population for examination. There are many other high-risk groups eligible for examination. Good drugs have been available since before 1970, and many doctors have prescribed according to their own experience and opinions. In the 1980s, a strategy for tuberculosis control in poor countries was tested by Dr. Stiblo in some countries. The strategy has 4 main points and are still part of the newest End TB strategy. The first point is to have political commitment in the country to run a tuberculosis control program, fund it sufficiently, and appoint a manager. The second is to identify the sources of infection. All tuberculosis patients will be treated, but there is more emphasis on detecting the most infectious cases by sputum examinations. The third is to let all new tuberculosis cases be treated with a standard regimen and ensure drugs are taken as prescribed by directly observing the patients swallowing the tablets. The fourth is to ensure stable supplies of drugs and materials for the program. Lastly, the standard recording and reporting of all cases is essential for running a program, both of planning supplies, knowing the local epidemic, and for identifying weaknesses. In the 1970s and 80s, it was up to the individual country to decide on their tuberculosis control. After 1993, the WHO declared a global emergency and created a global strategy using the experience of Dr. Stiblo and called it the DOTS strategy, which is Directly Observed Therapy Short Course. Basically, it aims to identify the sources and cure them. The most infectious cases are the sputum smear positive pulmonary tuberculosis patients. The WHO wanted all countries in the world to have the same strategy. Some countries resisted, but after the evidence showed clearly better results, this DOTS strategy has been accepted worldwide. The initial DOTS strategy was replaced by the Stop TB strategy in 2005. A new update in 2016 was called the End TB strategy. The same 5 principles were still in place. There are many stakeholders in tuberculosis control. National programs are the most important stakeholders, and most of them are members of the Stop TB partnership that is hosted by the WHO and has 1,500 partners. Finances in national programs should ideally be covered by the governments themselves, but some activities need extra funding. The Global Fund to Fight AIDS, Tuberculosis and Malaria supports many programs after applications. TB Reach is a funding mechanism inside the Stop TB partnership. It is supported by Canada and the Gates Foundation and others, and provide grants for improving approaches and technologies. FIND is another partnership involving governments, NGOs, and industry, and is focused only on diagnostics. Technical agents provide technical assistance to national tuberculosis programs and are members of the Stop TB partnership. The International Union Against Tuberculosis and Lung Disease, or the Union, is an NGO working with tuberculosis for 100 years, and they piloted the DOTS strategy before it was launched. KNCV is an old Dutch organization working all over the world with technical assistance for tuberculosis programs. The Green Light Committee is a technical group of experts reviewing applications to the Global Fund for second-line tuberculosis drugs. The Stop TB strategy had a vision of a tuberculosis-free world with relevant targets for 2015 linked to the Millennium Development Goals. The Stop TB strategy builds on the 5 principles of DOTS, which constitutes its first component, adding issues that need special attention. 2. Address care for special populations like patients with HIV-TB co-infection, multi-drug resistant tuberculosis, and poor and vulnerable populations. 3. Contribute to health system strengthening. 4. Engage all healthcare providers involved in tuberculosis control, including the private sector. 5. Empower tuberculosis patients and communities by advocacy. And 6. Research is also an integral part of the strategy. Now, the Stop TB strategy has been updated and is now called the End TB strategy. It was launched in 2016 and the targets are for 2035. It still builds on the DOTS strategy of finding and treating the tuberculosis patients. The goal of the End TB strategy is to end the global tuberculosis epidemic. The components of the End TB strategy are not very different from the former strategies. The pillars are care of tuberculosis patients, policies and systems to support it, and research to improve it. The first pillar is patient-centered care with early diagnosis, treatment of tuberculosis, management of comorbidities, and prevention. The second pillar is bold policies and supportive systems. This requires the following components: political commitment to invest in tuberculosis care, engaging civil society, ensuring universal coverage, and supporting social protection. The third pillar is research and innovation. This is development of new tools and ensuring uptake, and research to optimize their impact. In conclusion, the control strategy needs involvement from all parts of the society, and several mechanisms exist. All should follow the same strategy adapted to the local situation.